All right, welcome everybody to our first expert session on genetic testing. And before we get started and I introduce our expert, I just kind of wanted to talk about like the purpose and expectations of this session. So I know that genetic testing can be kind of a big question for a lot of people in this community. You know, how do I know I'm ready to know my mutation status? Once I know, I can't unknow that. So there's a lot of things that come into play with that as well. And I hope that this session just provides a little bit better understanding for you all who are facing that big decision, and just some more information in aiding you in taking steps to either pursue or not pursue genetic testing. So we're joined today by Jill Goldman. Jill is a genetic counselor at the Center of Excellence for Alzheimer's Disease at the Taub Institute and a professor of genetic counseling in neurology at Columbia University Medical Center. She specializes in hereditary neurological diseases, so those such as early onset familial Alzheimer's disease, but has also worked with other hereditary diseases such as frontotemporal dementia and Huntington's disease. Jill has been working as a genetic counselor since 2000 and has authored many papers and book chapters on this topic, including developing the practice guidelines. So these are guidelines that all genetic counselors follow for helping families go through genetic testing for Alzheimer's disease. So Jill, thank you so much for taking the time to join us today.
Thank you for having me.
So before we get started, you spend a lot of time with families and individuals who are at risk for developing early onset familial Alzheimer's disease. Just for everybody out there, that's kind of our term, but other people will use autosomal dominant Alzheimer's disease or dominantly inherited Alzheimer's disease. But you also spend a lot of time with other hereditary neurological diseases. So before we get started, I was just wondering if you would mind sharing how you got into this line of work.
Well, genetic counseling is my third career, actually. I started off in a PhD program in biology and quickly decided that I was not a lab scientist. I preferred talking with people. And obviously I had an interest in biology and genetics. But for many years, I ended up teaching high school and junior high school science, and then veered off into health education, during which time I got a second master's in educational counseling, which I didn't use the way I expected to. And then found out for the first time at a relatively late age that there was this career called genetic counseling. And so I went back and got the third master's degree and have been doing it ever since. And actually, I've been in neurology and specifically, in dementia since the start of my career. Moved to Columbia from UCSF in 2006.
Wow, so that sounds like such a perfect intersection, of all of your skills. You understand the science behind it, but you really love that human component.
Absolutely.
So that's great. Well, I know that there's a lot of confusion when it comes to genetics and Alzheimer's disease. And so I know many of our families and individuals in this community are well aware of what an autosomal dominant disease is, but just so that, we're all on the same page, I think it would be great to just talk about, what predictive genetic testing is, who is eligible for it. I think also too, because of, I know a lot of people have heard of ApoE4, and that increases genetic risk. And I just want to be clear that that is very different than the autosomal dominant mutations that cause early onset Alzheimer's disease. And those mutations are in APP, presenilin 1 and presenilin 2, or amyloid precursor protein and presenilin. And I was just wondering if you could speak to why, predictive genetic testing is different, you know, for somebody who has sporadic Alzheimer's disease, but maybe is at risk for inheriting ApoE4, you know, which increases your risk quite a lot, versus somebody who's at risk for, let's say, you know, their parent tested positive for a presenilin mutation.
Sure, sure. So there are really three different types of family histories that we see. Uh, the majority of people have sporadic Alzheimer's disease, and that is usually late onset, although it doesn't absolutely have to be. Um, and when we say sporadic, it's usually the first case of Alzheimer's in the family. I think now I should step back and say for someone who has late onset Alzheimer's disease, there is no appropriate genetic testing. Um, the second group of people have perhaps several cases of Alzheimer's disease in the family, and there may be some that are late onset, and there may be some that are earlier onset. More Alzheimer's disease than you would expect to have, but still not the autosomal dominant kind of family history we see in the Diane families. You don't see it every generation at an early age, and that's key. Almost always before the age of 65, if not even 60. And there may be some family members that have siblings or parents or even children with the disease and don't get it themselves. So that again is different than the autosomal dominant families. But when you see this family clustering, what you think of is not the three genes that you mentioned. You know, in all likelihood, we would test someone from that kind of family and not find a mutation in any of those three genes. But we think of risk genes. And you mentioned the most obvious, which is the ApoE gene. So, you know, this is a gene that everybody has. It comes in three forms, ApoE2, 3, and 4. And we know that ApoE4 is associated with a higher risk of Alzheimer's disease. And there is what is called a dosage effect, so that if you have two copies of ApoE4, you're at substantial lifetime risk. Okay, I want to stress that because that can mean to the age of 85 or even older. If you have one copy, you're at about a 3 times greater risk than if you have no copies. But as we all know, unfortunately, there are 6 million people in this country that have Alzheimer's, so we're all at risk, whether or not we have an ApoE, an ApoE4. There are plenty of people walking around with ApoE4s and even 2 copies who don't develop Alzheimer's disease, and vice versa. There are many people who do get it who don't have an ApoE4. So we say it's neither necessary or sufficient to get this disease. Whereas if you have a mutation in presenilin 1, 2, or APP, you will get the disease. Okay, so there are your differences. Now, why should somebody who has 2 copies of ApoE4 not get it? Well, we know there are many, many, many other risk genes as well, and some modifier genes that might actually reduce risk, which is what ApoE2 does. Okay, so it's not, when you're in a familial cluster kind of situation, there you would really have to have what is being developed now, which is called a polygenic risk score, where you're testing all known associated genes. And even then, you have to throw in environmental factors that might influence the gene. So it's a much more complicated situation.
So to reiterate, predictive genetic testing is really only meant for families with those autosomal dominant mutations in their family, correct?
That is correct.
Yes.
Although there are many people who want to be tested for ApoE4, and some who have been tested even through 23andMe.
Mm-hmm. Which I would love to get into later, but I'll save that for the end. So this idea of, oh my gosh, okay, I could possibly have a mutation, and like you said, if I have that mutation, there's a 99.9% chance I will get the disease. And I'll likely know my age of onset because that's when my parent got sick. So there's a lot of issues, related to, your own mortality and just psychology, and then family dynamics built into that. So I guess I'm just curious, from your perspective, what are some advantages or reasons why somebody would pursue testing, and maybe on the flip side, what are some inner disadvantages and why somebody shouldn't pursue testing?
Sure. And that's ever changing too, right? And what's making it ever changing are clinical trials.
Yes.
So with the availability of clinical trials, more people will probably opt to test than already do. When we look at all of these fatal autosomal dominant diseases, whether it be early onset familial Alzheimer's disease or Huntington's disease, of all the people who are at 50% risk because one of their parents has it, only about 20% of people even show up at a genetic counselor. And some of those people actually will decide not to test after thinking about it some more. I would say that the now 4 main reasons that people do decide to test are: number 1, reproductive options; number 2, life planning. Do I want to retire early? Do I want to go to medical school and then not be able to practice for very long if I carry this gene? So things like that. And then the third reason is I can't deal with this uncertainty anymore. I'm going to be better off knowing and being able to plan than not knowing and fearing it every day. And then the fourth is candidacy for clinical trials.
Which is relevant now because of the gantenerumab open label extension,
right.
By
Exactly.
Diane. Mm-hmm.
Yeah. So, and on the flip side, why would someone choose not to know? Many reasons. I think probably the greatest proportion of people who don't want to know think that they can't cope with the result if it's positive. There are some people who could cope with the result if it were negative, who are very invested in the family disease. There are plenty of people who say, I don't want to think about this the rest of my life. We're all going to die of something. I could get hit by a bus tomorrow and, or get cancer or have a heart attack or whatever before I get Alzheimer's disease. Why should I know? So the sort of the fatalistic outlook, and that's fine. There's no right or wrong in any of this. This is a very personal decision. I would say, looking at it from a genetic counseling point of view, we want the best outcome for folks. We don't want people testing if they think that they can't cope, or we think that they can't cope. So we strongly suggest that someone has a psychiatric evaluation before going through this. That maybe um, a therapist that they have been involved with for a long time, or it may be a therapist at the center that's doing the testing. Um, we know from the literature that the chances of a bad outcome are greater when someone has had a prior history of depression or significant anxiety. And we also see that people who haven't spent a lot of time thinking about the impact and ramifications of testing may not do well. Okay. So, the genetic counseling is really what I call anticipatory guidance, taking someone through, you know, all the possible things that might come up for them post results.
Hmm. And I definitely think, in my experience, with this community, I feel like there are people who find out, that a parent has a mutation and they right away have to know. They're like practical, they believe knowledge is power, they have to deal with this, they have to make a life plan, and they go on to get testing, which I should also mention, in the literature, all the literature we have on how people cope, these are people who chose to get tested, who
Right.
went through, like what
Exactly.
you said,
Exactly.
that rigorous counseling session and said, yes, there's no date on people who were like, maybe I'll, I'll continue with it. All those people dropped out. So we don't know how those people would cope, and they might not cope very well. Right.
Right.
Um, and so what I also noticed, so you have people who are, okay, I have to find this out, and then you have people who are strongly against it, like I can't handle this, I don't want to think about this disease, I've thought about it long enough, I just want to live my life. But then you also have people who kind of struggle in between, and it's like, one day they may think, okay, I want to know, and then there's another day and they think, okay, I don't want to know. So I guess my question to you is, in your experience, what would you tell somebody who's having those thoughts and feelings? And is there any sort of criteria that you notice in people who can cope well, especially for those individuals who are on the fence and not sure? I know you had mentioned, if you have a history of anxiety or depression, that it's probably not a good idea, for you to pursue that. But is there any other indications that might say, okay, we think that this person could be able to handle this information?
Yeah. So again, it's not so much that they have a history of anxiety and depression as that they haven't dealt with it. Certainly if you grow up in a family with these kinds of diseases, it, it's highly probable that people have experienced you know some a lot of stress, and as a result, you know significant depression and anxiety. That would not be unusual. um, if they are facing that and they are saying to themselves, I want to be in a good place, okay, and they are dealing with um, what the depression and anxiety is all about, and learning how to cope with those feelings, they'll probably do okay. Um, what we don't want is someone with active depression and anxiety without a support system, without a therapist helping them, without medication if that's necessary. We don't want them diving in. Um, it would be better that they just take their time until they're more sure that this is the right thing for them. Okay, people have to take their time. They can't make fast decisions. It's not like you should go into your doctor's office and say, I want this test. And some doctors will do it, and then they're stuck,
Mm-hmm.
because there's going to be a result there. And so I would say, really, really deal with your issues first. And when you think that you are, I can't give a percentage, but let's say 90 to 95%, you're sure you want to do it. I mean, everybody, is going to vacillate somewhat. And even
Mm-hmm.
after you get your result, you're going to go, why did I do that? But if you can be a lot more sure than unsure,
Mm-hmm.
the outcome is going to be better.
Mm-hmm. Yeah, I mean, it's so, unclear, I think, when you have that little shred of hope, that you're negative, right? Maybe you have a feeling that you're positive your whole life. Some people say that, they have a feeling, and you never know how much that small amount of hope that you're negative contributes, to your psychological state. And so once you can't unknow that. And I'm just curious, when you talk about outcomes, what are the outcomes reported to date? Like what do people what normally happens? Is there a timeline when people are depressed and when they recover? Is it kind of like winning the lottery, where it's like, you have this very intense emotional period, and then after a year, all of the psychological data says you kind of return to your normal levels of happiness and psychological state. So I'm curious what your thoughts are on that, on outcomes.
Yeah. Um, well, you've read the literature, so most of the literature says that people do have a period of time, where they have a psychological impact of the result, and then over time, and I think a year is probably what the literature says. They go back to baseline, and based on taking psychological assessments, before, right after, and 6 months and a year, whatever. Um, Obviously that's going to differ in different people. I
Mm-hmm.
think it also depends on your reason for testing. For many people who are trying to make decisions about IVF and PGT, having that result allows them to move on,
Mm-hmm.
and that's a good thing.
Yes.
And I think another significant part of a good outcome is having the support system, whether it be your family or a partner, or really good friends who are around you. That's really important.
Yeah, that's such a good point. I think a support system is so important during this period. And I should just say, if any of you are out there and you're thinking about undergoing this, that Youngtimers does have a support group for people who are thinking about, pursuing this, and it includes individuals who've already gone through it. So if that's helpful to speak to individuals who have already gone through it to understand what it's like on the other side, I would definitely encourage you to go to our website at youngtimers.org for more information on that. So let's say somebody decides, okay, I'm ready, to pursue genetic testing. So what should they set into place, before they contact a genetic counselor like yourself? Is there anything that you would recommend before they do that?
Well, before testing, not before contacting.
Okay.
I think everybody should realize that you can contact a genetic counselor. You can come in and have a consultation with a genetic counselor, and you can still decide not to go forward. And I think that's really, really important.
Mm-hmm.
Um, it should be in your control. You call the shots as to how soon you want to do it, or whether you want to wait. I have many folders with results in them that have not been returned because the person has decided that they weren't ready. Okay, and that's just fine.
Mm-hmm.
Yeah. The one thing that people should think about before they get a genetic result is whether or not they want to obtain life insurance and long-term care insurance. There is a law called GINA, which is the Genetic Information Non-Discrimination Act, and that protects you against discrimination for health insurance and in the workplace, but doesn't cover life insurance or long-term care or disability. And there are the veterans aren't covered by GINA, and there's a couple other situations that aren't covered. It is hard for young people to think about obtaining all that insurance. It's expensive. And we don't know for a fact how much discrimination there really is. But the fact is that if you're applying and someone says to you, what's your family history? You have to own up to your family history. You can try to maneuver. You can say, Mom has a neurological condition. But if they say what, you have to say Alzheimer's disease. And if someone says, have you ever had genetic testing? You can't lie if you already have your test result. That's insurance fraud. And theoretically, you could lose whatever money you put into it. So, this certainly isn't required for genetic testing, but it's something that we warn everybody about. And then, they choose what they want to do. Many people will decide long-term care insurance is going to be too expensive in the long run. I can't afford a good enough policy, so I'm going to establish my own separate bank account and contribute to it, and that's going to be my long-term care insurance.
You talked about how people can decide for themselves their timeline as far as testing goes. So I was wondering, I know there's a lot involved in the genetic testing process, but can you just give a summary so what patients can anticipate or expect what that process looks like? How many sessions there are, the length in between finding out your results and when you do the swab or have your blood taken, all of that.
Sure. Centers differ tremendously. If you're going to a Center of Excellence for Alzheimer's disease, in most of these centers will have you see a genetic counselor. The session will be about an hour. And then you will see a doctor, a neurologist, or a psychiatrist, or the combination. And each center is a little bit different in what they do. Some people will see a geneticist rather than a neurologist. But that person is going to be the ordering physician, because genetic counselors can't sign off for their own test. They can coordinate it, but there has to be an ordering physician. There are several labs in the U.S. that do this, highly specialized testing. An individual can't just go to LabCorp request and say, I want this test. It is a specialized test. And different labs differ in how long it takes to get results. It certainly is much faster now than it used to be. And I usually tell people about 3 weeks. Okay, and then they would come back in again with their support person and get face-to-face results. Nowadays, that's on Zoom in most places, but it is face-to-face without masks on Zoom.
It's crazy how everything is changing with COVID. But it's great that you guys can still provide those services, especially because I know it's an important question right now with the clinical trial going on. So I think another big barrier to testing is costs. So I know you mentioned that there's a couple of different, testing facilities, and they probably have different costs. But is there anything you can say related to cost that people can expect?
Yeah, costs has come down tremendously. Even a few years ago, some labs at least were doing full sequencing of each gene, and that was very, very expensive. Nowadays, the labs are doing next generation sequencing, so they're basically testing the entire exome, but only analyzing and reporting specific genes. That's done all at once. So it depends a little bit on what is known about the genetic cause in the family.
Yeah, so we could say there's two scenarios. One where they have the parents' DNA maybe, and another one maybe where they don't have it.
Yeah. So when they don't have it, and let's just say the parent has had an autopsy and we know it is Alzheimer's disease. Again, that's one scenario, and you would only test for the Alzheimer's genes under that scenario. But sometimes people have a family history of dementia, and we don't know exactly what kind of dementia because they can overlap. Mm-hmm. So if we don't know whether it is Alzheimer's disease or frontotemporal dementia, we would do a larger panel. As it turns out, for most labs, it doesn't matter how many genes are on the panel. It's the same price. Okay. The big difference is the more genes that you test, the more likely you are to get what is called a variant of unknown significance. Mm-hmm. So when you don't know what the exact mutation is in the family, you can do a large panel. You can find nothing. That would be a negative result. You could get a definite positive, which would be a known mutation in one of the genes. Or you could get one or more of these variants of unknown significance, which basically means that a change or changes in the DNA were found that have either not been reported or have not been proven to be associated with Alzheimer's disease or whatever the disease is. If you get a VUS, you're in the same boat you were before you tested. It is an uncertain result. Now, over the next few years, that result may change. The lab, with additional information in their databases, may go back and say that this is actually a benign change or it is a definitely pathogenic change. So you may get more information in the future.
And pathogenic means, that it's disease causing, right?
Mm-hmm. Yeah. Mm-hmm. Yeah.
So again, these, larger panels I've heard can cost, $1,600 to $2,000. Is that about right? Or
no,
is that less?
It is not.
Okay.
It is,
okay.
It is not. Okay. Labs are different, but there is no reason in the world at this point that you can't get a test for $250, no matter how many genes are on that panel.
Wow. So
And that does not matter if it is a blood test or a saliva test.
okay. So wow, that really, there is not really then a barrier to genetic testing like there used to be.
And that's out of pocket,
Yeah.
because people who are doing predictive testing wouldn't be covered by their insurance anyway, but because of possible discrimination issues, it's probably better if they can pay out of pocket to go that route.
Right. Yeah. Because then that information isn't in their medical record and the insurance company can't later on use
Well,
that
that
information.
depends too. That depends too. And that's a
Okay.
question, that's a question that people should ask their physician or their genetic counselor, prior to testing, because some places will do anonymous testing, other places won't. Some places put everything into the electronic medical records, other places keep shadow charts and don't. So, that
So if somebody's,
it should be transparent before testing.
yeah, so if somebody's very worried about this issue, they could possibly pursue anonymous pet testing or make sure that, the counselors and the neurologists use maybe paper charting instead of putting everything into an electronic database,
Right,
correct? Okay.
Right. Now, the problem with anonymous testing is that you can't prove it's you.
Right.
Okay, so if you are doing testing in order to do IVF, you're going to have to get retested.
Okay. That's good to know. And probably also if you're symptomatic, I mean, at that point, you probably can't do it anonymously. You would need to do it under your name so that you get the right Social Security benefits or, whatever that may be.
Exactly.
So let's say somebody, has a heart. We already mentioned it, that sometimes you can't get the DNA from a family member. So you would, have now this panel done. And let's say maybe you did identify a mutation, you now have information, right, about your family. And I think a lot of families struggle with the best way to communicate that information. And I think there's two parts to it. And I think both are equally important that we should discuss. The first one is, what do you tell your children? Because if you have a mutation, that means there's a 50% chance of passing that mutation on to your children. So I think, what age is the best? I'm sure that this is very personal and it's going to be very individual for each family and each child. But I think in general, it would be really great for people to just hear, from your experience, any thoughts and recommendations for, I think, having those difficult conversations.
Yeah, so I think, a lot of it depends on how old the person being tested is, and how old their children are. There are all kinds of ethical issues that come up when you're dealing with families. The first that comes to mind is, what if you want to test because you want kids and you want to know, whether you need to do IVF, and the family history is that your aunt has a known mutation, but your father doesn't want to test. And then you test and you're positive. So you have revealed both your status and your father's status. That's really, really hard. And that's something that certainly would be discussed in a genetic counseling session prior to testing. And I strongly encourage people to have a hypothetical conversation, with their family prior to their testing. I'm thinking about doing this. And if I do, I'd like to share results, but if you don't want them, I want to hear and respect your decision. So it is on the table before that piece of paper is in your hands. Some people go, no, you don't know my children. My son is extremely anxious, and I don't want to raise his anxiety anymore unless I absolutely have to. And they do know their children a lot better than I do. I may never have met these children. So, I think it's important to think about, but everybody does know their situation best. Mm-hmm. In terms of telling younger children, I don't think it's necessary. Younger children aren't going to understand. They don't have to act on anything when they are young. I don't know that there is a right age, but if the parent is sick, there will be questions. And again, you're not going to tell an 8-year-old because they're going to worry so much, but you might tell them a little bit. You might, just start introducing the whole concept of inheritance. Mom has this disease called Alzheimer's disease, and granddad had it too. And sooner or later, you're going to get the question, what about me? Mm-hmm. Am I going to get it? And you certainly don't have to go into the full genetics there. But, we don't know, some people have diseases in their family, and not everybody gets it. You don't ignore the question, but you mm-hmm. keep on adding at age appropriate levels. I think it's almost harder with the older, the young adults who haven't been told and then are smacked in the face with it, when they're in a relationship and the parent finally feels that they have to know.
Right.
And then there can be a lot of anger. Mm-hmm. Why wasn't I included in this? Don't you think, I'm old enough and competent enough to be able to deal with it? So I think you have to look at that as well.
Mm-hmm. Yeah, those are so, it's a really big, decision to make, to tell your children. And yeah, I think everybody will find their own path that works for them. But yeah, I definitely agree. I think being honest, with your children, that's, I think, a really good way to go about it, and I like your idea of age appropriateness, so it doesn't feel like that just smack in the face. But yeah, I think once children get to that reproductive age, it could be really important to disclose that information. So I think that's a really important point. So just along those lines, I think other people also struggle with, telling their extended family, and this could be family that maybe doesn't know about the risk. And I didn't know if you had any strategies. Is it your responsibility then, with this newfound knowledge that the mutation, to share that with them, and the best way to go about it? Everybody's different. Some people don't want to deal with this disease at all, so it can feel very confrontational. And I didn't know if you had any suggestions for facilitating that kind of dialogue, just because you want, your family to be aware, and if there is a clinical trial, you maybe want them to know about that and have an opportunity to participate. Yeah.
It's a really good and very difficult question. And families are families. There are, many families that are estranged and they don't want to go near the part of the family they don't talk to. Certainly ethically, it is important information. And in a way, people have the right to know what they're at risk for. That doesn't mean that someone has to call a relative up and say, "I've just been diagnosed with, and I have this mutation." This is where genetic counselors can really help, and one of the ways they can help is to help compose a letter that is a little bit more generic. We're writing this because we think that this is important information that you might want to know. Someone in the family has, been, been diagnosed, and we also want you to know about this clinical trial. If you're interested, please contact. So that's a little bit less personal, but it's still getting the information across.
That's great. I didn't know that you could ask genetic counselors to do that for you. So that's
I mean, you send it, but you compose it together.
Yeah, that's really great. Okay, coming up on our last question, and I just think this is really relevant because, with the advent of all these commercial, DNA sequencing kits like 23andMe and Ancestry DNA, I think some individuals may wonder, why should I even go to a genetic counselor? A lot of people are now turning to like personalized medicine and, Googling all of their medical conditions and, wanting to have the information for themselves. And so I would just, from your perspective as a genetic counselor, just again reiterate, I think the importance of why, if you're going to pursue predictive genetic testing, which is different, finding out your mutational status versus finding out your history, your ancestry, or, APOE is, that's a whole other issue to find out that way. But, why it's important to go to a trained genetic counselor for that testing versus, just doing it on your own with one of these commercial kits.
Number one, you can't do it on your own. Okay, none of the companies, have approval to test for, dominantly inherited Alzheimer's disease or Huntington's disease. The only way you could do that is if you, do a 23andMe or whatever test, and then ask for the raw data.
Right. Mm-hmm.
Okay. And if you read the small print, you will read that they cannot they cannot take responsibility for what that data says, except for the traits that they release on their regular testing result, which have been have been confirmed in a CLIA lab, which is the an approved, federally approved lab. When you get your raw data, what people do is they stick that data into another website that analyzes the data and spits out the results. And there was an article in the New York Times, I think 2018, about a young man who did this and found out that he had a presenilin-1 mutation with no family history at all. His parents were in their 60s and just fine. He panicked and tried to get his doctor to test him in a CLIA lab, and his doctor thought the whole thing was just ridiculous and wouldn't do it. So he sent a second sample to Ancestry.com. And he waited till he got that result, and that result was different. He didn't have the the presenilin 1 mutation. And he sort of liked that result better, but he thought he would send a third sample to 23andMe and got the same result he got the first time, which is pretty predictable, because if they have something wrong, with what is generating their raw data, then it's going to be wrong all the time. Eventually, he got clinically tested and he was negative. And this shows the problem with these companies. I think what they give you is probably pretty accurate, but you have to look at it with a grain of salt, because it's only a result, say, in a breast cancer gene, is really only applicable to a Ashkenazi Jewish population, because they're only testing 3 mutations that are found in that population. If you're not Ashkenazi Jewish, or in fact, even if you are, you could have a mutation someplace else in the gene, or in another gene that causes breast cancer. And so you're not getting the whole story, and you really have to read between the lines. If you go to a genetic counselor, you're going to know what you're testing for, number one. And you're going to be able to really think of the ins and outs of that testing, and the impact of that testing on you, on your partner, on your family, in all the ways that we described before.
Which you can't get on your own.
Which you can't get on your own.
Yeah. Yeah. So, I mean, not only are you probably not getting the sensitivity and, the scientists who are just looking at those specific genes and making sure that, it passed all the necessary controls, because you're looking at an entire sequence, and a lot can go wrong when you're looking at an entire sequence, but also you're losing that ability to really, I think what's most important about genetic testing is taking time, as you said, to really explore if you're ready for this result,
Exactly.
Mm-hmm. Well, Jill, thank you so much for, again, taking time out of your day to talk with us about this really important issue for our community. I think you made some really great points and brought a lot of insight. And so just thank you.
You are very welcome.